Hello, my name is Kerry James, and I'm the Chief Exec of the World Hepatitis Alliance. And the World Hepatitis Alliance is a network of over 300 patient-led organizations in almost 100 countries, all focused on fighting hepatitis and reaching its elimination by 2030. And today, I'm very happy to welcome you to this very special webinar on the prevention of mother-to-child transmission of viral hepatitis. And we have a fantastic lineup of speakers and panelists which will share their knowledge and their personal experience and their expertise in this area. Just to say that this session is pre-recorded, so it's not live, but do feel free to leave messages and comments in the section below, and we'll try to answer them to the best that we can afterwards. So without much further ado, I think we should get started. So I'd like to first introduce Philippa Easterbrook, who is a senior scientist in the Global Hepatitis Program at the WHO in Geneva, to give us an overview of mother-to-child transmission and its prevention. So Philippa, over to you.
Well, I'm delighted to have the opportunity to present at this webinar on the new WHO guidelines on the prevention of mother-to-child transmission of hepatitis B using antivirals that were launched on Tuesday, July the 28th. This slide summarizes the global epidemiology and burden of hepatitis B infection, with an estimated 257 million living with chronic hepatitis B and an annual estimate of 900,000 deaths, largely due to cirrhosis and hepatocellular carcinoma. The graph at the bottom shows the distribution and the burden across the different WHO regions, with about 2/3 of all infections in the Western Pacific and African region. The top two graphs show the impact of hepatitis B vaccination on the prevalence of infection in children under 5 years. On the left, we see that before 2000, around 5% of all children aged 5 years and under were infected with chronic hepatitis B, as compared with in 2017, where this was less than 1%. A major global public health success story. Well, in 2016, there was a landmark WHO product of the Global Health Sector Strategy for Viral Hepatitis, with a goal of elimination of viral hepatitis as a major public health threat. What do we mean by elimination as a public health threat? That's defined as a 90% reduction in incidence and a 65% reduction in mortality, and particularly for hepatitis B, a 90% reduction in incidence of new infections in children aged 5 years and under. Well, these impact targets were estimated as achievable based on scale up of 6 synergistic interventions, both preventative and testing and treatment, as shown on the table below. Highlighted are those preventative interventions that particularly relate to the impact on the incidence of new hepatitis B infections. That is the use of 3-dose hepatitis B vaccine for infants and prevention of mother-to-child transmission using either birth dose vaccination and or other approaches such as antivirals. And shown on this table are the baseline 2015 coverage levels, the 2020 target, and the 2030 target of 90% with 3 doses of Hep B vaccine for infants, 90% with birth dose. Well, this slide shows where we are as of 2015 on the global progress towards the 2030 elimination targets for these service delivery interventions. In the light bars are the 2030 targets, and the dark bar where we were at in 2015. And you see immediately that the 3-dose hepatitis B vaccine, that we are above 80% and well on the way to reaching the 90% target for 2030. But for PMTCT, that is the use of birth dose as well as other measures such as antivirals, the coverage is less than 40%. This slide summarizes the three main interventions for the prevention of transmission of hepatitis B infection at birth and in the first years of life, with the interventions at the bottom of the pyramid benefiting the largest number of people and required and as a foundation for the interventions at the top of the pyramid to be effective. First, 3 doses of vaccine and universal timely birth dose, this being the main defense against perinatal infections for all infants. Secondly, the use of hepatitis B immunoglobulin, largely in high-income countries and where there are, of course, supply issues with quantity and quality in many low and middle-income countries. Thirdly, the use of antiviral prophylaxis, which is the focus of the new WHO guidelines, which can make a significant difference for the subgroup of women with high hepatitis B viral load. For the first of these interventions, the Hep B vaccine, a few facts and figures. The vaccine is 90 to 100% effective, safe, and appears to generate lifelong immunity. It's most effective when given as a post-exposure prophylaxis to prevent mother-to-child transmission and administered as soon as possible after birth, the so-called birth dose. In that first dose, it is administered through the use of monovalent hepatitis B vaccine, but thereafter, for the subsequent doses, usually combined with other vaccines, particularly as part of a pentavalent vaccine. It's freeze-sensitive and heat-stable. This slide summarizes the existing WHO recommendations on infant vaccination. As mentioned, all infants should receive their first dose of vaccine as soon as possible after birth, preferably within 24 hours, and to be followed by 2 to 3 doses to complete the primary series. Currently, the majority of countries are providing hepatitis B birth dose in addition to infant vaccination. And the slide, the charts on the right show the current and incremental number of countries, now 109, that are providing birth dose. And the top chart shows the, again, increasing coverage with birth dose to around now 44%, with much higher rates in the WIPRO region, but very low coverage at present in the Afro region of around 4%. So a major strategy going forward is to promote hepatitis B birth dose vaccination through immunization programs working with mother to child. In terms of use outside the cold chain, WHO is encouraging the relabeling for use in a cold controlled temperature chain. And although there's no pre-qualified product yet, it is clear this would facilitate immunization for home births. This summarizes the existing WHO recommendations on treatment in 2015. And this relates, of course, to pregnant women also for consideration for treatment, long-term treatment for their own health, independent from the new antiviral prophylaxis for use to prevent mother-to-child transmission. At the time of these 2015 guidelines, no recommendation was made on the routine use of antiviral therapy for prophylaxis, largely because there were still ongoing trials and the lack of programmatic information as to the positioning of antiviral prophylaxis in the overall birth dose and infant vaccination programs. There were also existing recommendations for testing in pregnant women for hepatitis B, HIV, and syphilis that were part of the 2009 consolidated guidelines on HIV testing, that all pregnant women should be tested for HIV, syphilis, and hepatitis B surface antigen as early as possible during the course of pregnancy. So what is the rationale to now be considering the use of antivirals as a measure to prevent mother-to-child transmission of hepatitis B? Well, the main reasons this was reconsidered, that was there's new evidence from trials. Second, request from regions and countries in the context of triple elimination of HIV, syphilis, and hepatitis B for mother-to-child transmission, and concerns that the timely birth dose alone may not be sufficient to reach the elimination goals in children, the 2030 elimination goal of less than 0.1% prevalence of surface antigen in children under the age of 5 years. So this slide summarizes these two new recommendations on the use of antiviral prophylaxis in pregnancy. First, that pregnant women testing positive for hepatitis B surface antigen positive, and who have a high viral load of hepatitis B DNA defined as greater than or equal to 200,000 international units per mil, are recommended to receive tenofovir prophylaxis from the 28th week of pregnancy until at least birth to prevent mother-to-child transmission. And this is in addition to the 3 doses of Hep B vaccination, including timely birth dose. Second, given the often limited access to hepatitis B DNA assays in low and middle income settings, and where DNA testing is not available, e-antigen testing can be used as an alternate to determine eligibility for tenofovir prophylaxis. It is recognized that implementation of this recommendation of antiviral prophylaxis will vary by geographic region, depending on what the current prevalence is in 5-year-olds and in the general population, what the coverage level is of immunization, including birth dose, availability and access to affordable HPV DNA assays, and access to testing and antiviral prophylaxis in antenatal settings. For example, in high endemic settings with high prevalence of hepatitis B surface antigen in the general population and in 5-year-olds, and where there is currently suboptimal coverage of infant hepatitis B vaccination, increasing coverage of timely hepatitis B death is the real priority to achieve greatest impact at the lowest cost. In low endemicity countries, low prevalence, which have already achieved high coverage of infant vaccination with or without birth dose, hepatitis B screening in pregnant women, and then the use of tenofovir prophylaxis in those pregnant women with high hepatitis B viral loads would help prevent further perinatal infections. So given the challenges, what are the opportunities, particularly in a world affected by COVID? And I think these are important messages to the community, that there are real efficiency gains to be made through integration of the Hep B, prevention of mother-to-child transmission, as part of an overall triple elimination strategy, linking with HIV, syphilis, together with hepatitis B in maternal and child health services. Indeed, 2 WHO regions, the Americas and the Western Pacific, already have frameworks for this triple elimination initiative. And WHO is also working to include hepatitis B into their program for how to validate EMTCT, the elimination of mother-to-child transmission of HIV and syphilis, and now the plan is to add hepatitis B. So what are the conclusions and the priority measures to improve prevention of mother-to-child transmission and hepatitis B control in a world affected by COVID? There's measurable progress on the Hep B control through immunization delivery at present. The key challenges are that more than 50 countries still need to introduce birth dose, and the coverage goal of 2030 is high, 90% within 24 hours after birth. And the big challenge is that there are still a high proportion of unattended births, with less than 50% in the Afro region of deliveries delivered by skilled birth attendants. It's also clear that we cannot reach the global elimination goals, the 0.1% for 2030, through prevention of mother-to-child transmission alone. You do need to achieve high coverage of the Hep B 3-dose series to reduce infections, horizontal transmission in young children as well, and to prevent adult infections. To achieve the overall goal of eliminating mother-child transmission needs the multi-pronged approach of the vaccination in infants, birth dose with the antivirals. And clearly COVID has changed what was planned and what may be possible in the future. And I'd just like to acknowledge the many contributors to the guidelines process, both in the evidence generation and in the guidelines development group, and our regional colleagues. Thank you.
Thanks, Philippa. It's great to hear about all the amazing work WHO is doing in this area. So now we're going to take it from kind of the global health level down to the community level and really into a personal individual level. So how this issue affects mothers and children. So I'm very happy to introduce Dr. Sue Wong, who is a primary care physician and is also president of the World Hepatitis Alliance. Sue, over to you.
Great, thanks, Carrie. And I think this is a great topic because we are really, prevention of mother-to-child transmission is really at the crux of us being able to eliminate hepatitis B. And so much of what we hear about is the guidelines and the recommendations and the medical side of things, but there's another really important side of it, which is the human aspect of women living with hepatitis B, getting pregnant, having their infants, and the whole process of taking care of the mother, providing care for her for the viral hepatitis. And what we're focused on now is obviously during pregnancy to prevent viral transmission. But I think we have to also remember the mother for herself is really important, even prior to pregnancy and after pregnancy, and that she's living with this infection during this whole process. And then obviously the other side of things, making sure the infant gets the vaccine at the point of delivery, whether at a hospital or other birthing center, and then the transfer of care to the pediatrician. So it's a very complex thing. But what I want to focus today is really about the impact on people living with hepatitis, their families, and also the community aspect of things. So what I have here on the slide is just some snapshots of women and what they are saying in terms of the struggles that they have living with hepatitis B. And these are all consults that came in to the Hepatitis B Foundation, which basically conducts about 12,000 consults in general about hepatitis B from people living around the world through their social media. They have Facebook, Twitter, they have, people will email them directly. And a lot of these stories are quite heartbreaking. And you see that these are not the things, even for me as a physician, my patients don't tell me these things a lot of times. And so when I read through these, I realize there's a whole world of experience that those of us in the healthcare field don't necessarily hear, or even, working in the programs, we don't see these things. And yet this really just showcases the great burden that people have living with Hep B. So we kind of categorize some of these. So on the left, these kind of stories really highlight the stigma, discrimination, intimate partner violence. So we have one woman saying, I don't think I can ever get married. No one is accepting Hep B. Life has become so lost, so dull. I fear living now. Next, I just got diagnosed with chronic hepatitis B, and to be honest, I feel like committing suicide. I'm just 23 and I've had one partner, only one partner in my whole life. So you see there's some, misunderstanding that this is an STD. Next, my hubby's family wants to abort my child. He stopped taking care, stopped talking with me, blocked me from every side. It's killing me inside. I don't want an abortion. I want my child and I want to be cured. Next, he slaps me every day. I'm dying every day, but I can't tell my father. He'll be sad after hearing that I am suffering from the situation. I love him more than my life. How can he doubt on me, on my nature? My hubby said that he hates me. He will talk to other Randys or prostitutes, but not with me. I'm a very dirty girl that's affected with Hep B. So you see there's definitely some intimate partner violence situations and a lot of struggles people have with family members, pushing for abortions. And we've heard of stories of spouses, women whose spouses, they may be living in a multi-generational family where their in-laws actually will kick them out of the house and they've become abandoned because of the hepatitis B diagnosis. All right, and the next on this side, these kind of showcase, just kind of show the lack of education, services, and access to birth dose that a lot of these women are facing. So I have a child, I'm a single mother. Nobody told me that I was to give her an injection immediately after birth. Even the doctor who told me I have it, the hepatitis B, never explained it to me because my daughter may have to contract it from me, but I've not checked her because I'm scared I can't face the shock of it. So he told me I can use the one which is usually administered for 6 weeks, that for me, I can use it in 12 to 24 hours instead of waiting for 6 weeks. So she was basically being told to use the pentavalent vaccine as a birth dose, which is not what's recommended. So next, my daughter's doctor recommended to buy a pentavalent vaccine, which cost $5,000, and to give it to her. Then, until then, they told me to stop breastfeeding. July 28th, they're going to give this vaccine to her for once. And then next, my doctor, where I'm doing my antenatal from tells me to wait for 6 months to vaccinate my child, which is risky, like you advised me. It's my prayer that my newborn is safe from the virus. So we see there's a real access issue with getting the vaccine, or even understanding what they're supposed to do in terms of protecting their babies, and that the birth dose is not a guaranteed service around the world. And so these women are really struggling, trying to find the best way to keep their baby safe. And it's obviously, as a mom, this is one of the most important things you want for your baby. And it's a great source of guilt, I think, to feel that that you are unable to protect your child from an infection that you carry. All right, so next, so these were some slides I had prepared for the validation meeting, which Philippa had mentioned. And one of the aspects of validation is making sure that countries address equity, human rights, and community engagement. And so they had gathered a number of us community members to really go through what we thought were the top concerns for HPV elimination of mother-to-child transmission, and how to make sure that that was incorporated into the ultimate validation process and efforts that a country would submit for validation from WHO. So I hope the stories that you just heard really highlight how important it is that we're able to use this process to ensure some level of protection for women living with hepatitis B. And this discrimination is not just women. It's obviously, discrimination against Hep B can happen in men as well. And you can see that where it can impact is unemployment, education, and even housing and benefits, things that we don't really think about. But even in the US, we've had a number of stories of healthcare workers who have not been able to complete their training, potentially kicked out of medical school or residency because they were found to have hepatitis B, or they lost their job because of it. And in many countries, even to apply for school, you have to disclose your hepatitis B diagnosis. And in certain parts of the world, particularly, I know that in Asia, there were some places where you were not allowed to apply for nursing school or dental school or to be a doctor if you had hepatitis B. So, and then also work visas. We know that in the Middle East, there are some countries that don't allow you to get a work visa if you have hepatitis B. So there's some far-reaching impacts on one's life if you have hepatitis B. So the intimate partner violence that we saw in one of the stories, divorce, abandonment, and so protection of legal rights, particularly in women. If we're talking about a country where women don't have the same legal rights, this is an opportunity to really try to push for that as well. So next, in general, the same healthcare rights we would want afforded to women during this time. So privacy and confidentiality, obviously, so there's not stigma. There have been stories of women being treated differently, even by healthcare staff because of their hepatitis B status. And in the end, everybody just wants fair and equal treatment, regardless of their medical condition. And then thirdly, really, it's a lot of the crux of it is the availability and the access of these important services that we know are critical to EMTCT. So, and especially in vulnerable populations. So what we really want seeing done in these validation efforts is that there's some effort made to ensure that vulnerable populations such as migrant populations or immigrant populations who already are at risk for not getting healthcare services, but that there is a realization that they carry a larger burden of hepatitis B in many, many countries. And so this needs to be addressed, because really, if we don't address some of these health equity issues, we certainly will not be able to get to elimination. So for hepatitis B for women, what we're looking at is obviously the screening of or the identification of the woman during pregnancy. So a surface antigen test should be part of all antenatal screening packages. Surface antigen is actually a rapid test now too, so it's available, a point of care test. They aren't that expensive, but it's still it's still a limitation, the cost of doing the screening test, but we believe there's a real potential if we're able to do the triple elimination screening along with HIV and syphilis, that you would also include hepatitis B as part of it, and it would just be part of a package. Next, that once a woman is found to have hepatitis B, that they would get the full evaluation for Hep B during pregnancy. And so one of the most critical tests is the viral load, the Hep B DNA, to assess how high her viral load is and if she's at risk for transmitting the infection vertically if her viral load is high. So and this will be part of the new recommendations by WHO. And one of the provisions in there is that if a country, if it's not, viral load is not available, then the E antigen could be a substitute indicator, although the viral load is still a much more accurate test of risk than the E antigen. Thirdly, that if the mother does have a high viral load, that she would be able to get the antiviral therapy. And the recommendations for WHO are specifically during pregnancy, but on a bigger human rights scale, we believe that women should be able to access this before pregnancy as well, because honestly, some women will need the medication just for their hepatitis B alone, not just for the sake of preventing viral transmission during pregnancy. And so potentially they would be, if they were already being treated prior to pregnancy, that would already reduce the chance of vertical transmission. And then even after delivery, if she needs the antiviral therapy, that she would be able to continue that, not just lose the opportunity, lose the access to treatment just because she's no longer pregnant. And this happens in the US too. There's some women who are unable to get insurance except for when they're pregnant. And so they have insurance coverage during pregnancy, but at a couple months of when the baby's about 4 months of age, they'll lose their insurance. And so then if they were on antiviral therapy for themselves, then they lose that. So that's an issue that we need to address. And then really importantly is that there's education. So from what we can see, there was a lot of gaps of knowledge of what the baby needs, what the mom needs. And actually, I think a lot of the stigma is because of knowledge. So I believe that a lot of the issues that patients have with their family members, not understanding Hep B, thinking that it's only an STD and not vertically transmitted, would really, education would be a huge component to combat that stigma, right? If people knew that it was transmittable, that there's nothing to be ashamed about, that it's, for many, many areas, it's mostly vertically transmitted. This would go really far in terms of, in fighting stigma discrimination. And so this is, I think, a grassroots thing, and I think the community could do a lot actually in terms of raising awareness in general about hepatitis B. So next, birth dose, critical, really part of the elimination efforts is that birth dose would be part of all national guidelines, and if available, HBIG would be given to these infants born to mothers with Hep B, although we know that's expensive and not realistic in a lot of settings. And then lastly, but also very important, is that the infants would get a serology test after completing their Hep B vaccine. And this is to confirm their immunity. And if they're not immune at about 9 to 12 months of age, then they need to get a second round of vaccine. Or they also potentially, we need to think about the fact that they could have been infected. And so this is something that needs to be done. And often, even in the US, it kind of falls through the crack because not always does a pediatrician realize that the mother of the infant had hepatitis B. And so for us, a lot of times it's the health department calling the pediatrician to remind them to do a serology test. And so this is important because if a mom knows or father knows that their child needs this, they can advocate to make sure that the pediatrician actually runs this test. But this is another important component to really confirm that we were successful at preventing transmission and the baby has immunity, or that if the baby does have the infection, that we're able to get them care and be monitored and within for their hepatitis B. All right, so what are some of the implementation considerations for equity, human rights, and community engagement? So I really like us just kind of taking a step back, and looking at this statement that was part of the WHO guidelines for Hep B prevention, diagnosis, and treatment, because it just shows you that human rights is a core part of it. So ensuring that human rights and ethical principles of fairness, equity, and urgency guide the development of national treatment policies so that barriers in access to testing, prevention, and treatment services particularly among certain populations, are addressed. So this just shows you, this is not a trivial part of elimination, but if we don't figure out the fairness, the equity, and the urgency part of it, we will not get to elimination. And that word urgency really strikes me because I think we're all seeing what happens when you have a pandemic and COVID is, you know, in the center of everything, and just how much can change when you have something that urgent, right? Like mountains have moved, and the, you know, telehealth has become a big thing. Things can happen, you know, there's momentum, there's political will. When we get that, we have that sense of urgency. And I think we really need to have that for Hep B too, right? There's a whole generation of kids we could prevent having the infection, and yet the statistics show us that there's still 1.8 million 5-year-olds that we think are living with Hep B, and this is in the era of vaccination. So we really, you know, need to, you know, just have that urgency that, like, yes, this is something we can do, and we're going to resolve to do it. So obviously, every country, countries have very different levels at where they're at in terms of human rights. And so it is predicated on the country having an enabling environment for human rights, equity, and gender equality, inclusion, and human rights engagement. We do believe that there are certain, you know, that including some sort of health equity and human rights is really non-negotiable for validation. And some of the enablers that we've identified for elimination and equity would be if the Hep B services were covered by universal health coverage. So if a country has universal health coverage or some national health programs that include Hep B screening, you know, diagnostic coverage and care, those would obviously help with equity because it would already be covered, and there would be less of a differential between people who can afford, you know, health insurance or afford care versus those who may not be able to pay, you know, for insurance or fee for service. So, or in countries that have insurance plans, that the insurance plans would cover Hep B services with little cost burden to patients. So next, simplified diagnostics and treatment algorithms we believe are really critical to advancing equity, because obviously the more complicated we make testing and treatment, the harder it is going to be for the frontline people to deliver this or primary care. And we really think this has to be task shifted and decentralized from specialists to frontline workers. Otherwise, we're not going to be able to get to everybody, right? Not everybody has access to tertiary centers or specialists. So the simpler we can make things, and I think the WHO guidelines coming out were a real effort in trying to simplify things, but we need to go, you know, even further than that, I think, with the general treatment guidelines for Hep B, because they are quite complicated right now. So, but earlier universal treatment may assist with women being at. So this was just like an extension. There's some discussion of whether or not we've seen this happen with HIV, with Hep C, where it went from certain people being tested to now treat all, right, for HIV or Hep C. And so there's been ongoing, you know, back and forth and debate about whether or not you know, universal treatment of all people with Hep B would be an option, and if it would somehow allow us to cover more people, because we know liver cancer rates are still on the rise and not enough people are getting treatment. So, and then integration, obviously, of Hep B into primary care, HIV, or sexual reproductive health and harm reduction and OST programs would really help expand access to these hepatitis B services. All right, in terms of the role of community engagement, I think we always want to remember the concept that it's nothing about us without us. So no programs about us, you know, no guidelines about us, you know, without some involvement of the patient voice. And so this is as part of kind of addressing how potentially the community could be involved with validation of hepatitis B, EMTCT, in a country. So what we would recommend is some sort of formalized process where a Ministry of Health would have a national validation committee in country. And as part of that committee, there would be a community advisory board. And this board would have diverse representation of people living with hepatitis B and some who don't. You know, potentially there's people who work in the community that are not necessarily living with Hep B. and that they must represent key populations. So if you're in your country, if you know that certain immigrant populations, you know, have a big load of a large representation or burden of Hep B, that they would be represented on that board. A formal survey of the community to identify the gaps in needs or challenges in accessing care. And then a process for the Ministry of Health to address and document progress, so that it's not a static thing. It's not a, you know, check off yes or no, but that you can show that there's been progress, because every country is going to start at a different level for these different measures. So next would be involvement of the community in the WHO hepatitis validation process, which is happening right now. So we had that first meeting last month about EMTCT, but during the summer and in September, there'll be another meeting looking at other issues of hepatitis validation. And we believe that the community should be incorporated as part of this, because you know, to make sure that everything you know, addressed really resonates and is realistic and really represents the community concerns for hepatitis validation. So you know, representation was, we just had a few people who represented last time, but we would, you know, expect that they would expand the representation to make sure we have a good balance and representation for both Hep B and Hep C organizations. And then before the September validation meeting that WHO will be having, you know, we're recommending or asking for formal meetings preceding the meeting to help prepare. So, and I think, you know, we really believe that the communities are important partners, that that we can help expand and make the validation process something realistic, but also to motivate countries to do so, and also to activate the community to put pressure on their countries to actually, you know, put this as a priority, to want to be validated, right? And then that holds the countries at a higher standard as well if they're pushed to do it. And it should be a process that highlights the successes too. So we want this to be a chance for you know, that we would see a lot of good best practices that could be shared around the world by looking at what happens to different countries. So, and separately, it's a little complicated, but if EMTCT is also included as part of the triple elimination with HIV, syphilis, which is validated externally by GVAC, then the GVAC committee, we believe, should have some, right now it's focused on HIV and syphilis, but that there would be members with the hepatitis technical expertise and people who have some experience. Sorry, my mouse is very sensitive. That they would have people who are familiar with hepatitis advocacy and treatment rights, because what we really see is that the communities are different. And so a lot of the things that we're using for, you know, what the communities and HIV and Hep C advocate for are actually quite different for hepatitis B. And so they are not necessarily something you can just pick up and replicate exactly for Hep B, but that they need to be, you know, tailored a little bit, at least for Hep B and as part of the triple elimination package. So, and then kind of as a backdrop for all this is that if you really want sustainable community education, engagement, and advocacy, there needs to be some way of funding it or supporting it. We know that there's a lot more resources for HIV, and you see that there's a robust community voice with that. And one thing we have to remember is that we don't have those kind of resources. And so there may be some support that's needed in order to make sure that we do have community leaders that can actually participate. So that wraps up my talk, Carrie, and then we will have a discussion on this. So, you know, I'll just leave it at that. Thank you.
Thanks, Sue, and thanks for sharing those personal stories. They really give, you know, a context to what we're talking about today, and really shows why this really matters. So next, I would like to introduce Dr. Cynthia Tamanju from the University of Cape Town. And she's going to talk about actually some work that's being done on the ground in Namibia. So Cynthia, over to you.
Thanks, Gary, for the introduction. And thank you, Sue, for your lovely presentation. It was really powerful messages in there. So I think that we're discussing a very important topic when moving towards eliminating hepatitis B globally, not just in Africa. And for that today, I'll be sharing some of the work that our collaborators and some colleagues perform on this specific topic of preventing mother-to-child transmission in Namibia. And this was part of the work that I did for my doctoral degree. So just to give an overview what I'm going to cover, I'm just going to start with a brief status quo of what the hepatitis B virus in Namibia, and then I'll go on with the rationale of the overall project itself and the roadmap that we set ourselves to follow. And I give a little bit of our main findings and end up with what we thought is really important to remember going forward with eliminating mother-to-child transmission of Hep B. Like many other African countries, we know that Hep B is highly endemic in Namibia. There is a prevalence of about 11.8%. And as you can see on the diagram or the map that I've shown here on my right-hand side, the highest prevalence of the infection is found in the northern part of the country. Also, historically, like many other African countries, horizontal transmission has been the main mode of transmission of the virus in Namibia. But since the implementation of childhood vaccination in the country in 2009, and that was vaccination starting from 6 weeks of age, the current main mode of transmission of the virus isn't really clear. And that uncertainty is fueled by reports of high prevalence of the infection among pregnant women, but also among infants below the age of 1. But the great thing about this, and I think this is where Namibia is highly placed as comparing to other African countries, is that they do have policies in place for preventing mother-to-child transmission. And those include routine antenatal screening for hepatitis B at the laboratory though. They have vaccination starting from birth, but also have passive immunization with immunoglobulin for HPV-exposed babies. Now, the big question is, are these things working? And if they are working, is it something that's feasibly implemented, not just in Namibia, but also elsewhere in Africa? So can we really use Namibia as like a proof of concept, if we can say it like that, for the other African countries? So what really drove this study was the fact that when we thought about them having routine screening of hepatitis B, but it's performed at the lab. And there was a paper that came out and basically highlighted that screening is not systematically done in 11 out of the 13 regions of Namibia. And it's very easy to think that the potential cause of this could be the high cost of routines of testing at the lab. And even if it isn't, if we're thinking about the proof of concept for the rest of Africa, testing at the laboratory is not really a practice that many countries in Africa can implement or sustain. But also testing at the lab comes with potential loss to follow-up of these hepatitis B infected pregnant women. This is definitely not what you want to have. It's a situation that you want to have when you're thinking or when you're wanting to prevent mother-to-child transmission. And so comes the question of, okay, so if we change the way we're doing screening from the lab, let's say, to the point of care testing, if we make sure that we have clinical pathways to follow up these pregnant women and make sure that we prevent transmission, with all of these tools, which one works the best, which one is applicable to the setting, and in terms of effectiveness, cost, and many other things, acceptability from the community, from the healthcare workers, and so on and so forth. So we set up a roadmap, and really this is just a snapshot. The roadmap was much more longer than this, but I'm just going to focus on these 5 ones. So we wanted to train healthcare workers for Hep B diagnosis at the point of care testing, and have them understand what it is or what evolves around hepatitis B care for these pregnant women and potentially postpartum. And with rapid testing, that means we needed to establish quality assurance for rapid testing, obviously, educate the pregnant women at the antenatal clinic, because we felt that that was a very important step for them to understand why we need their cooperation, why we're calling them back to the clinics for checks up and checking up their babies. And from there, then being able to have them agree to being tested for using rapid testing at the antenatal clinics. And lastly, to follow up these pregnant women and their babies. So starting with training, we decided, obviously it included rapid test training, but also hepatitis B care. And the allele determined surface antigen kit was our test of choice to detect these hepatitis B infected pregnant women. And those women were seen at their first antenatal care visit of their pregnancies. And so we trained the nurses and the health assistants at the clinics that we were working at, and made sure that they understand what the process is, why it's important to follow these processes. And not only them, but any other healthcare workers where the clinics were interested in learning how to do rapid testing for hepatitis B were invited. And thankfully, we had the help of, we had the assistant of Alia in Namibia to do so. Now, we know that there are a few reports on the lack of knowledge regarding hepatitis B, both diagnosis and care among healthcare workers in the literature and even on the ground. And so we went on and we're providing a few presentations. They were kind of like webinars or presentation every Thursday while we were busy with the study, where we basically give information, teach the healthcare workers on diagnosis of hepatitis B, caring for pregnant women or even patients with hepatitis B as a general at these facilities. And we also distributed some of the charts that you're seeing on this slide to remind the nurses of how to do the rapid testing, you know, if by any chance they forget something or how long it takes for them to wait for the rapid test result, but also the guidelines that were available back then, and that those were combined. We combined the WHO guidelines for testing and then the American guidelines and European guidelines that were available for preventing mother-to-child transmission. So we compiled them in this very short algorithm chart that we distributed to not just the nurses, but also the medical officers or any other healthcare workers who were interested in knowing more about diagnosis and care for hepatitis B. So for the rapid testing, obviously, because this is not something that we were going to do at the lab in the control setting that we know of, and with using powerful diagnostic assays and platforms, we needed to make sure that we have a system to make sure that all positive patients will be detected and the negative patient will not be misdiagnosed. So we established a quality assurance scheme, which is, I feel like, was a very important and a very powerful thing here, because it empowered those healthcare workers, you know, that they were sure about the result that they would give to the patients. So we had a weekly testing of hepatitis B surface antigen positive and negative controls at the antenatal clinics. And I've shown here what the quality control record should look like. So every single day of the first antenatal care visit, there will be a nurse or a health assistant who will do the testing of the controls. And then another nurse will come and check that everything is working, or myself will check it, or the matron will check it before we started testing the patient, the pregnant woman. And we also had a repeat of every fit sample with a negative result by the rapid test, again, to make sure that a negative patient was not misdiagnosed or we weren't missing any positive patients. And then came the very exciting part, I would say, was for me anyway, was health education. So fortunately in Namibia, they do health education in the mornings of the first antenatal care visit. So that's where they talk about HIV testing, what is the behavior of those pregnant women, they shouldn't travel long distance and so on and so forth. So we use that opportunity to add also information on hepatitis B. So the health assistants and the nurses will also give information on what is hepatitis B, how do you get hepatitis B, what is mother-to-child transmission, and what are the consequences of those. And we had a specific focus on chronic hepatitis B and liver cancer. And I have to admit, we did use the liver cancer because we felt like that would catch more of the attention, because like Sue mentioned earlier, no mothers want to have to give birth to a child with hepatitis B and the child having to suffer at long term with liver cancer. So that was really what was our drive in adding liver cancer among all the information that we provided to this pregnant woman, but also reassuring them that there are measures for preventing mother-to-child transmission. And this health education was also used for us to recruit these pregnant women in our studies. So we managed to recruit about 515 pregnant women, and so they were tested using rapid testing, as shown on the procedures that I've shown on the slide. And the results were interpreted as we're seeing again on the slide. And we actually showed this diagram to the pregnant woman, showing that, okay, this is the work that the nurse is going to do, and this is where we need you. And this is how we are going to interpret your results. So if you want to check it, you can check it yourself, and if you see two bands, that means it's a positive test, and if you see one band, that means the negative test. And obviously, we gave her information in terms of what would happen next if she's positive, and what our recommendation if she tests negative for hepatitis B. So for those that tested hepatitis B positive, we went on with viral load testing, and to determine those who were at the high risk of transmitting the hepatitis B to their babies. And those with a very high viral load were called back and to the clinics and offered tenofovir from the third trimester of pregnancy till 1 month postpartum. And the reason we did till 1 month postpartum was because, as I said, we were following American and EASL guidelines. But obviously, At the end of the day, they will come back after 1 month and have their liver function testing and the viral testing. And then from there, the medical officer will decide whether or not this pregnant woman should continue on treatment or if treatment should be interrupted. So that part was left at the discretion of the medical officer at the antenatal clinics. But postpartum, which is the important part afterwards, all the infected pregnant women were called back to the clinics to verify the baby's immunization status. So we wanted to check, does the bird dose vaccine given at birth and not 1 day or 2 days later? Did the baby receive immunoglobulins as it is in the policy? I mean, we know that many things are written in policies, but when you go on the ground, it's actually not being performed. So we really wanted to make sure that this specific policy on immunoglobulin is actually performed and how far or how much of it is being done. And they were also called back with their babies to test for hepatitis B at 6 weeks for acute infection, but also at 9 months to check for chronic infection. So that's where we did anti-S, hepatitis B surface antigen, and DNA viral testing. Now, I won't really go into the specific of the result, but really draw what were our main findings. So we found that identifying this pregnant woman, hepatitis B infected pregnant woman, is a crucial step in eliminating mother-to-child transmission. And this can successfully be done using rapid test-based screening as opposed to doing the lengthy laboratory-based testing, which is expensive and can lead to loss to follow-up of these pregnant women. And what was most striking is that antenatal testing does not only benefit the baby itself, but also the mothers. It empowers her to seek chronic care or access to treatment services. I mean, some of the infected pregnant women would come back to me and ask if I could advise on the doctor that they needed to see for their care, if there are any specific changes in their lifestyle that they need to do. Others will ask if they need to have their family members tested for the virus. And even others will they come back and ask me, how much is this vaccine? Can you please write on my health book that the nurse has to give the vaccine and the immunoglobulins to my baby at birth? I mean, to just show you how powerful this simple practice was, just telling her, telling her that she's positive and giving her the information that she needed there for protecting her baby and herself. But we also found that screening and treating highly infectious pregnant women and with pediatric immunization is effective. I mean, it's not just in Asia, but it's also applicable and works in Africa. However, we do have to acknowledge that the implementation of this intervention calls for access to hepatitis B immunoglobulin, but also low-cost viral testing, which might not be feasible for some African settings. And that's where political buy-in comes in. I mean, we can eliminate mother-to-child transmission of hepatitis B, but we really do need that political buy-in to have access to immunoglobulin if feasible, to have access to those low-cost viral testing, and basically to make an informed use of the resources that are available. And again, they can only do so if we have robust local hepatitis B epidemiological data. If it's not there, then they can't make any informed decision on how to use the resources that are available or how to draw some more resources that are needed. And so though it's feasible, we also need to acknowledge that the strategies that are going to be used are going to be customized for each setting. So it's not going to be this one size fits all. We need to think about epidemiology of the infection, the availability of resources, the cost of these resources, bearing in mind equity. I mean, being now in health economics really taught me how important it is to think about equity and fairness. You really have to make sure that whatever you are implementing in policy is not just happening in the big capital, but also in those rural areas. Those pregnant women, they need to have access to those services. Otherwise, we aren't doing our work properly. And so I would like to thank a whole bunch of fantastic and amazing people who were part in this huge project, as well as the funders. And thank you very much.
Thanks, Cynthia. There's so many important lessons there, especially the one about ensuring that programs are really tailored to the local needs of the community. So now we're going to move on to our discussion section, which will be led by Sue. So I'm going to hand it over to Sue.
Is our Afro regional board member for the World Hepatitis Alliance, coming from Mali.
I think in order to reinforce the mother-to-child transmission prevention for hepatitis B, especially in Africa, it would be great to have a reinforcement of recommendation of WHO, because we're still having, it stands out like mother-to-child transmission is the reinforcement of the immunization with the birth dose. I think there is a urgent need to start with the screening of every pregnant woman. Because of that, we're gonna be working on finding those mothers who are infected and who are highly infected. Those moms can transmit to their child, their newborn, even before the birth. So in this case, birth dose might be done to a already infected baby and it would not serve. So there is an urgency to start by screening every single woman. There is a need of political engagement. Of course, there is a 2016-21 World Global Health Strategy, a sector strategy for hepatitis, but still more need to be done in terms of financing of hepatitis care. This part is really missing, because as we can see on HIV, on other diseases like TB, malaria, there is any found destiny in order to work on hepatitis B, or quite a few. And unfortunately, political will is much missing, especially in most African countries.
So we want to welcome everybody to the discussion and panel part of our webinar, and welcoming back Cynthia and Philippa after their great talks. But we also have with us Lian Tran, who is the regional board member for the World Hepatitis Alliance. She's representing WIPRO. She's Vietnamese and living in Australia. So she's got some great experience, great insight from many countries. And then we have Dr. Manal Al-Sayed from Egypt, who is, I don't know if you need an introduction. You are the person for pediatric Hep B and Hep C, never letting us forget about the children in viral hepatitis. And so we are really excited to have you two here. This will be very exciting. We are looking forward to a lively discussion with our panelists. And I just wanted to kick off sharing my own story about being somebody who's living with hepatitis B and having to go through my 4 pregnancies, kind of worried and thinking about preventing viral transmission from me to my children, and what that was like. And I feel when I hear the stories that I had shared earlier in my talk from other women around the world, I realize how how fortunate I was that I live in a country where I have available specialists, and testing is available, and birth dose within 12 hours is available along with HBIG. But even being a physician, there was still quite a bit of angst, like going into it, not knowing that, is my viral load going to go up? Like my viral load is usually quite low in the thousands, but what if I'm one of those people who has a flare during my pregnancy? And so, what's interesting and what I see also in these pregnant women, Cynthia, you probably share this too, is that during pregnancy, women become very careful about their health. They will do anything during their pregnancy to keep the baby healthy. They will quit smoking. They will, start exercising. They will go on that low, carb diet if their glucose is high. And so it's a real opportune time also for us to help women take care of their own health. So for a lot of the women who are diagnosed for the first time with Hep B, it's a great time to, tell them this is not just for you to prevent transmission to the baby, but this is for you as a woman, for your own health, to get care for hepatitis B. And so for me, it was the same thing, trying to do everything best for my kids. And, I have to admit, I'm not a great patient, so I often don't get my viral load as soon as I should. But during pregnancy, I was really good with getting my viral load. I went to see a maternal fetal specialist, and got my viral load, and went through the whole discussion of my risk factors, and I ended up not needing any kind of antiviral treatment, thankfully, and the babies all got their vaccine within 12 hours and their HBIG, and I'm being a physician, obviously I have that on my head. This is what I do, so I was very much an advocate, and there were a couple times where actually when I went to get my blood drawn, I had to tell the technician which lab to order, because, the doctor just scribbles it on, and then they open the lab book and they're like, which viral load is it? Is it the quantitative, the qualitative? So I'm there telling them it's this one. And this is what happens. Sometimes there's a lot of stuff that falls through the crack, because not everybody is well-versed with what, viral load testing, or they had ordered my genotype and all sorts of other things like mutations. And so I could see where that would have gotten messed up if I had not been there saying, oh, this is the test you need to order, or I need to go get this test right now while I'm doing my glucose tolerance test, for my pregnancy at like 22 weeks. And so, but I think it's a chance to realize the woman is really her own advocate and the best advocate, because she cares the most. So the education is really critical to make sure that this information is not just out there for the specialists and for the doctors and the healthcare providers, but it needs to be translated for patients so that they're armed with it and they can go seek healthcare, right? Cynthia, like you're saying, once they know they have the diagnosis, they will do the work of making sure that they can get care. They'll go far, they'll go to a hospital that they wouldn't usually go to, they'll find that specialist. So we need to empower patients with that ability to do that. So, because even for me, like when my infant, when my children were about a year and they were supposed to get their antibody test, my pediatrician, it just kind of slipped their mind. But so I had to be there to remind them, and then they got a call from the health department to make sure that the antibody tests were done. And one of them was ordered wrong, so we had to bring the baby back again for another painful, phlebotomy experience. But you do that when you know that it's that important. So, but even for me as a physician, it was not, it was overall a very, I think, non-exciting thing, but still there was still a number of challenges and things that had to be done, to make sure that the kids were successfully vaccinated. And thankfully they're all Hep B antibody positive. So, really was a story to vaccination and, all the steps that we've just been talking about and how important it is to, and I just feel so at peace knowing that they don't have to worry about living with Hep B and getting viral load testing and being worried about liver cancer. It's such a huge burden off a mother's back, knowing that that they didn't get infected. So I wanted to say, ask if Lien wanted to share anything from her own experience as well.
Yes, so thanks for sharing that. That is really like that brought me back to the time that when I figured out that I was pregnant. So it was like I kind of forgot about my Hep B for quite some time because, okay, I was young. I think like young people was great. And then whatever, I'm still healthy. I do nothing, like not taking any medication. And it was good. But actually that's the point when it came, when I found out that I was pregnant. And then the word of mother to child transmission came into me. I felt really stigmatized when first hearing that thing. It's just like, I feel like I have that guilt. So will I be giving something bad to my child? So that's when the desire, like the kind of like the desire to do the best, to find the best way to make sure that your child is safe. I was luckier than a lot of my friends in Vietnam. So I gave birth to both of my children in Vietnam. So I was a lot luckier than many people. So some of my friends only knew that they had Hep B when they were like 39 weeks pregnant. Then, so nothing can be done by then. And then HBIG or even the birth dose was not like widely available in Vietnam in the night, like few years ago, like 10 years ago. I gave birth to like at a private hospital where they did have like everything, a really like proper antenatal Hep B care, so like all the things. So, and then also like HB and the birth dose as well. But I remember one like a little bit like a kind of strange thing happened when I gave birth to my second child. So for the first child, so the doctor, I mean the hospital knew that I had Hep B. So like right after I gave birth, so they gave HB to my kid, that's it. But for the second one, they didn't do it. They came out to meet my husband and asked us to pay for that before they can do that. Like even like we were still at the hospital, and then nothing will be so I mean like we have to pay for everything for the delivery later on, but they specifically asked to pay for that. And then I figure out later on, so they tell me, because it happened before, like a mom living with Hep B, and then the hospital like gave HB to her child, and then the woman and the family was really, really unhappy. And like they blamed the hospital and they denied to pay. So that's why they explained what happened, why they had to do it. So I think like it feels like the feeling of being a mom will bring you to the point like you start thinking about what can be done for yourself and for the children. But then like the thing is not enough. You need to know, you need to have the knowledge, you need to have the awareness, like what best. It's just not like the desire from the inside, but it needs to be backed up by knowledge. So like anytime when we talk about like community education, I think that's the key, like key for like the mom knowing what best for them. And then also for situation when things are not there, they know what to demand. I specifically want to talk about that because just a few days ago, I heard about the case of a hospital in Hanoi, like in the middle of Hanoi, the capital city of Vietnam, a really big hospital, and they have not given any birth dose, like Hep B birth dose for children born from that hospital for the last 5 years. And the reason was given like they had no incentive by doing so. And then it just took them time to actually to explain to the moms and the families that they are going to give some shots to like the tiny baby. And that's difficult for them. And they do not have any further incentive. So if the moms and dads knows what best for them, they would like require that. So I think that's important.
That's great. Thanks so much for sharing, Leon, your personal experience. So it's interesting to see that, you know, even between pregnancies, you had very different experiences. And so one of the first questions I want to start off with are kind of what you think are the top barriers or challenges that people face currently. And I know, Manal, I'm looking at you because we've had these conversations about what you see parents struggling with in Egypt in order to get, you know, exactly what Leon is saying, getting the vaccine or you know, getting the things that they know are important, but not necessarily easy to access. So I'll let you start off.
Yeah, thank you very much, Sue. That was wonderful. The presentations were fantastic. And hearing the personal experience is really great. And I hear a lot of experience from parents. And I just had a call from one of them today. She used to be my patient. She had cancer and she was treated by chemotherapy, and she had hepatitis B, and she was treated by lamivudine a long time ago. And I used to see her 2 babies. Unfortunately, she came to me after delivery, so they were both infected. Both had hepatitis B. They've been followed up. They were on lamivudine, and then she disappeared for a few years. And she called me today. One of them is 14 years old, and the other is 12. And she hasn't been doing any investigations for many years for both of them. And she said, it's expensive. I can't afford it. The viral load is very expensive. The tests are very expensive. I said the simple liver function would have sufficed. And if you had an ultrasound and you haven't got in touch with me for so many years. So I think one of the main barriers, it's not only the problem with awareness, but also the problem with the cost, especially of the viral load for follow-up, not for the women and the children. And this is one of the key problems and the key, I think, obstacles that we're facing. As far as the birth dose is concerned, it took us 5 years to convince the Egyptian Ministry of Health to introduce the birth dose within the vaccination program. And we started in 2018. And by the end of this year, hopefully, we would have covered the whole nation with the birth dose of the vaccine. Although we started vaccinating since 1992, but the birth dose was just introduced 2 years ago. And it took many, many years to convince the governments. I think this is one of the key messages, that the community should be very active in convincing the political leaders of the importance of the birth dose and how much money it would save the government in the long term if they start by giving the birth dose right now. It costs a lot to test, it costs a lot to treat, and to follow up. The follow-up itself is very, very costly. So it's much easier to prevent the infection and transmission of the infection. And I think one of the messages also, there's not only in some of the countries might be, it doesn't only prevent hepatitis B, but Delta virus. We keep forgetting that the birth dose of the vaccine or preventing hepatitis B transmission from mother to child also prevents Delta infection, which is common in some countries like Mongolia, Pakistan, and among others. And I think Philippa would agree to this message. That we're also preventing Delta as much as we're preventing hepatitis B. So awareness among the public, awareness among the obstetricians who have no clue about hepatitis B and what does it mean. And they're the ones who usually see the women in the antenatal clinic and they advise them. So I think it's very important that you target the obstetricians, you should target the pediatricians. And I think you should engage a lot of key stakeholders to get eventually to the political advocacy. This is very important. This is a huge part of the community work that we are expecting from you, actually, as World Hepatitis Alliance and other NGOs working in other countries.
Great, thanks, Manal. I think that's a great segue in terms of how the community can really engage and advocate for this process, for us to transition to asking Philippa about the new guidelines that are coming out for PMTCT and what you envision the role could be for community organizations in terms of implementing these new guidelines.
Thanks very much, Sue, and thank you for the very powerful stories. I think, you know, at its heart, these are the stories that really inspire and shape policy development, and we must not forget that. So I'd just like to emphasize one point, which is that the big driver of chronic infection, which causes the mortality, causes the liver cancer, causes the cirrhosis, is almost entirely driven by the mother-to-child and horizontal transmission. So that is why this is so critical. If we are to control the hepatitis B epidemic, we must control the early childhood and mother-to-child transmission. So that is why, even though there's been huge success, it's probably one of the greatest public health, global public health success stories, is the vaccination, the use of highly effective vaccination in infants and in birth dose vaccination to prevent and control hepatitis B. But even though we've achieved great success and there's been a huge decline in the prevalence of infection in 5-year-olds from about 5% before the vaccination to now less than 1%, we need to go the last mile to really completely address mother-to-child and early childhood transmission. And so that is the purpose of the guidelines. We already have guidelines on vaccination that's being well adopted in most settings, with more than 84% globally, where there is the use of the third dose of the hepatitis B vaccine. Birth dose globally is around 40%, but very low in some regions. So there is a gap. And therefore, there is now the opportunity with these new guidelines is to further address and add another tool in the toolbox to eliminating mother-to-child transmission, and that is the use of the antiviral drugs during pregnancy in those mothers with hepatitis B infection who also have a high viral load and are therefore at risk of transmission. So we see this as adding on to the good vaccination policies that are already there, adding on to the existing recommendations we have that all pregnant women should be screened for hepatitis B as well as HIV and syphilis, because we're also talking about potentially triple elimination of those 3 infections. And so this is now a very valuable additional measure to be taken. Thanks.
Great, thank you. So we've been talking about lack of awareness being an issue, you know, some of the gaps from testing and vaccination. One of the things that I hear come up a lot is, you know, home births, right? And the issue with getting birth dose to women that are not delivered in a hospital setting. I'm curious what you guys think in terms of how do we bridge that gap, and what are you seeing in some of your areas for maybe some novel solutions? I believe that the vaccine is actually stable, even though it's not you know, approved for that. And so I know there have been discussions about whether it could be approved for you know, not cold chain delivery. So curious about some of your experiences with that. Cynthia, do you want to start?
The thing is, in Namibia where I worked at, many of these pregnant women will attend antenatal care, antenatal clinics for delivery. But one of the things that I think in a case scenario where we're working, that if the mother can't find someone to bring her to the clinic and she has to give birth at home, it's important to have these kind of information given to the nurses, because I've noticed that they trust the nurses, they trust whatever the nurses and the doctors talk about. So it would be great to have the nurses and the doctors educated about the fact that the vaccine doesn't have to be kept, you know, at the hospital, at the fridge, but it can also be, you know, at room temperature. And therefore advise those women, if possible, to send someone maybe, you know, a week or 3 days before delivery to the hospital to purchase or to get the vaccine, or purchase it themselves and keep it at home for when, if in case they give birth at home as opposed to at the healthcare facility. And there are other ways, I mean, there are many other ways that we can think of, but unfortunately, which might require some community healthcare workers being around, especially for rural areas where there's not access to some of these services, or where the hospital is too far for a pregnant woman to go to. So it'd be good to have also community healthcare workers, if possible, to educate these pregnant women, and if needed, to be able to give those birth dose vaccine to the mothers. So on top of my head, that's what I can think of. And I know there are new technologies coming out. I have seen that there's those little packs that you don't even need. They have like some kind of temperature check to tell you whether or not the vaccine is still fine. I haven't seen it myself, but I've read that it's kind of like it's useful, and it's something that we could possibly think of for these home deliveries.
Great, thanks. Manal, do you have any experience with some of these? I know you've had some crazy stories too of women not being able to get vaccines and having to purchase it and keep it for them.
Yeah, that was before the introduction by the Ministry of Health. I think before the past 2 years, we used to have issues with accessing the mono vaccine, because it was all the combined vaccine for hepatitis B with other vaccines given at 2, 4, and 6 months. So the mono vaccine was not available, and of course the HBIG wasn't available. We used to just get it. It was really very hard to get the access, the HBIG for women who were infected. And at that time, there was no even studies for tenofovir during pregnancy, so we had nothing but to try and give the vaccine, the mono vaccine. I think I like the idea of having something to check the temperature or say whether this vaccine is active. And this has been implemented before for the polio vaccine. The polio always had this kind of sticker with colors And if the circle changes color, this means that the vaccine is inactive and you can't use this vaccine. So I think this might work, but this needs some work with the WHO, I suppose. I'm not sure if Philippa, do you have something about the cold chain and having the vaccine outside the cold chain, and what are the measures used to make sure that the vaccine is active at all times?
Yes, I mean, I think there's a number of different strategies that can be used to facilitate the address the issue of the cold chain. But I think the particularly important one is in sub-Saharan African setting, where 60% of the deliveries are outside the hospital. So probably the most important thing to address is to identify the skilled birth attendants who are able to provide the birth dose outside the hospital setting.
But they need to be trained. I think this can be part also of the community services and work and support for women, and training women who are giving assisted deliveries at home or assisting deliveries at home. So I think this is one key thing that the NGOs and the civil society can work on.
Yeah, that's a good point. So, and I think one of the things that I keep hearing surface that is good for us to really think through is how do we align, the PMTCT issues with other efforts, right? How do we make this not just a siloed thing, but how do we work with different partners and agencies? And so one of the advocacy efforts we've been trying to do is work with the Global Fund and try to get more inclusion and of coverage of hepatitis services as part of the Global Fund, which is mostly focused on HIV. But there are some opportunities, and I think what's relevant to PMTCT is the use of tenofovir, which is utilized for HIV as well, and there's the opportunity for countries to use their global fund mechanisms to purchase tenofovir, and that is something that the community can raise awareness for and push if it's not being done already, if access to tenofovir is an issue. And so I think there are other opportunities too. I was thinking about how Gavi is covering the birth dose, and which is delayed by COVID. But that will happen, and that will have a big impact in Africa. But are there other things that you think we could align with? And we've talked about also aligning with women's health issues, right? Making this not just a hepatitis issue. What are some other things you guys have thought about how we can get this out of just a hepatitis thing, but to make sure we partner and align with, universal health coverage, obviously, or just other antenatal, maternal, child health efforts?
Yeah, and also with non-communicable disease clinics, because women who go for diabetes checks on regular basis, or are diabetics or hypertensives and go on regular basis for checks, I think those can be at some point tested for hepatitis B. And at least you can know their status and try a little bit integrate some other activities that are done specifically for women. Some countries also have programs for breast cancer screening. And there are many programs that are specifically tailored for women. And I think we can just try and integrate as much as we can, just adding on this component to the other components, to the other health issues.
I think just to add to Manal's comments, I think there is a real opportunity with triple elimination. And I think the Global Fund replenishments offers the opportunity for an integrated approach, and through strengthening maternal and child health services. So this is an opportunity to promote testing for hepatitis B alongside HIV and syphilis. You've already mentioned the tenofovir. And I think with the future opportunities from Gavi, which is really hoping to support particularly the operationalizing of the birth dose. It's not just procuring the birth dose. This is about all the operational issues you've just been flagging. And so I think there's an alignment of the stars here in the near future. And we have to be smart and use these existing funding sources to strengthen the maternal and child health and vaccination program.
Great. These are great thoughts. So I just have 2 more questions. So, you know, as we're talking about this great alignment of the stars, right now we have this horrible disruptor of COVID. And so I'm curious what people are thinking in terms of what do we think the impact of COVID is on PMTCT services, children who are being born during this time. You know, have we seen, and what are your thoughts of what we should expect and be worried about in terms of this cohort of children, in terms of, you know, what they might not be receiving, and if we're going to see a surge in potential, you know, more breakthrough infections. So I want to put that out there, see what you guys think.
So if I may, I think my biggest worry in this thing is disruption of stock, but also fear of the pregnant woman to give birth at the hospital. I mean, we already see it with diabetic and hypertensive people who are scared of going, or even with HIV infected individual, scared of going to the clinic to collect their ARVs or to do their glucose or blood pressure check because they're scared of catching the virus. Now I'm putting my shoes in a pregnant woman who is thinking I'm going to be, you know, exposed and have all these people around me to help me give birth. Who is infected? I mean, it's a hospital setting. And so that fear kicks in terms of, what if I go there and I give birth, but I also catch something else that may predispose me and my child to something more fatal? So that's where my fear is in terms of COVID. You know, these women being scared of accessing antenatal care services or giving birth at the healthcare facilities, and therefore having access to the birth dose vaccine wherever it's available, but also stock, because, you know, with the borders, everything is closed. What's going in, what isn't going in. So even if they have stock, maybe they had stock for 2 months. Some countries couldn't have the power purchase of buying for 6 months or 10 months in advance. And so what happens with all this thing with that, you know, frontiers being closed, borders being closed, there's no stock coming in. And you've got this courageous pregnant woman coming in and giving birth, but their babies do not receive the birth dose vaccine. So those are really the 2 areas where my worry is, I have to admit.
Yeah, I would like to add also not only the unavailability of stock of the vaccine, we had shortages in the hepatitis B medicines because of shortage in accessing the raw material and getting the API to those companies, the local companies that are producing the generics. So we had shortage also in hepatitis B medications for quite some time. It's becoming better now, but initially the first couple of months we had a huge problem to supply. We have 9,000 patients following up in our national liver centers and being treated for hepatitis B, and we could not dispense the medications for hepatitis B for 2 months or 3 months. Unlike hepatitis C, where we had a lot of medications because we have companies producing raw material here. So this was adding to the problem, and I know from the reports from WHO and UNICEF that there was a huge disruption in the vaccination for children globally, and we did not reach the last mile, as Philippe said, and only 84% coverage for vaccination for children globally, and now we're going backwards, and with increasing conflicts as well in the region. You can hear reports coming from Yemen that there are 1 million children who are not vaccinated, and they're likely to die from malnutrition. So I think there are lots and lots of issues also that are added to the problems with the COVID crisis.
Yes, and I think you know, one of the most clear learning experiences from COVID is not just the direct impact of COVID, but the indirect impact on disruption of services that you both talked about. And I think, as Manal said, absolutely there is clear evidence of significant disruption to vaccination. And so a focus going forward needs to be on maintenance of essential services and maintenance of vaccination. And that is now a big drive in various countries, and WHO is supporting that, and the need for catch-up vaccination. We may have missed the birth dose opportunities in some cohorts of children, but at least we need to ensure that there is good, swift catch-up measures taken to mitigate the impact. And some recent modelling work has been done highlighting the impact in the absence of catch-up of how a cohort and a generation of children would be affected. So I think going forward, and that's where the community, I think, plays a very important role in really emphasizing the re-establishment of vaccination services and catch-up. Thanks.
Great, thanks everybody. Those are really sobering thoughts, but I think it is good for us to think about this and you know, stay alert and aware and proactive about these issues as we move forward, to try to help with some of that catch up and making sure that even in the pause that we're able to catch up from that. So my last question is, you know, think about all this great work we have ahead of us, what you would like to see kind of as your wish list of like top thing you'd like to see to really make elimination of mother to child transmission a reality. And I'll start. And I also want to really say that, you know, very excited about WHO's theme this year for World Hepatitis Day, which is a HEP-free future. I think our webinar today has really embodied what we're trying to do, which is, you know, really give the next generation this gift of no HEP or hepatitis elimination. And we have all the tools here, but it's just a matter of, you know, putting all this together, right, to make it happen and solidify the success of eliminating hepatitis B. So I think the HEP-free future message is so hopeful, and it's something I hope we can drive forward this year for World Hepatitis Day. For the Alliance, we are also continuing with finding the missing millions, and I think they go well hand in hand. And so this is a chance for us to really get that visible and out there. So, you know, we're encouraging everybody to utilize those resources. There's a lot of great things that you guys have on your website for sharing on social media, a lot of which is focused on maternal to child health services. So in terms of me, what I feel like I'd love to see, and actually in light of COVID, to make elimination of maternal to child transmission a reality. And I think we've kind of talked about this, is really a patient-driven, a community-driven movement. You know, something where I think that now that we are all so virtual, there's a real opportunity, right? Telehealth has a life of its own. In the US, you no longer have to be licensed in a certain state to see patients from that state. So you can actually, I living in New Jersey, could see a patient in California. And so there's a real, I think, in some ways, dismantling of the barriers of access too, because we all now have, you know, remote, and obviously internet access is not available to everybody, but still it is a great equalizer in some ways, right? We don't have to travel. Nobody has to fly anywhere. And so we do have access, more access than ever in history to great information. And so I think one of the things so on a side note, I also had a recent battle with breast cancer, and I found the breast cancer community incredibly empowering, so much more useful to me than I had ever imagined. You know, I was diving deep into the medical literature, but in terms of living day to day with the disease, having the community of other people who are living the disease day to day is really what other patients need. And so as we're talking about empowering women, you know, and this is something the Alliance is working on, we are really trying to empower the patient community through online forums. Is something we're envisioning, a chance where people can find all the information from other peers and, you know, have the reputable information at their fingertips, because we find that it's difficult. There's a lot of bad information out there as well. And I think if we can really empower a patient movement for pregnant women and their families, this would help, I think, them. I mean, one thing you're seeing a lot is just there's a lot of fear, uncertainty, people feeling isolated and scared, but giving them a community of people like them could really help with that, not just providing medical information, but also just feeling like they're not alone. And in that way, I think we really raise up a community of active, participating patients. So that is my vision. And so I will pass it on to you guys to see what you guys think, and then we'll have Carrie close. Anybody want to go next?
Yeah, I would like to go next. Maybe I would like to see young girls, adolescents being tested in schools. We should start very early. We should not wait until they get married or they are active sexually until they get pregnant. I think we should start very early. And I think awareness among children and among adolescents should start in schools. And this is something also community can work on. This is really important. I would like to see also all the vulnerable and marginalized populations getting tested and treated, like migrants and refugees. There are 10 million refugees according to the UNHCR in the world, and they are just at a very high risk of infection. They've been exposed to violence, they've been exposed along their trips from one country to the other to many factors that would have exposed them to a high risk of infection. And they are not receiving the vaccination as they should. There are lots of conflict zones where children are being left without vaccines, they're left without treatment, and women are being undermined and stigmatized. I would like to see a world that disclosure of hepatitis B status would not prevent you from being employed, would not prevent you from being stigmatized in school. School children are being stigmatized if they know that they are infected with hepatitis B, or they're not allowed to play sports with their peers. So I think there's a lot to be done. And I'm hoping that with your very, very hard work and advocacy, you can help as a community to support these kinds of obstacles and issues that we'd like to see the coming generation free of hepatitis.
So I think, Sue, you really, it's like you read through my mind. I really want to see, you know, empowerment of these pregnant women, because I feel like you said, it's only a woman who can protect her own child, because she will battle and go through fire and everything else to make sure that her child is safe and free of anything bad that could possibly happen. But the other thing that I wish, and I really hope I would say, is political buy-in. I mean, we've seen in Egypt with hepatitis C how powerful political buy-in is. And so I wish all these African countries or anywhere else in Asia or anywhere else in Europe and America could just have this will of taking care or making sure that these affected population are taken care of. Because I feel like they are the people who make the decision at the end of the day. They are the people who provide the resource and who provide the money and so on and so forth. The WHO is there to greatly help them and assist them in terms of guidelines and showing them the ways of doing things. But at the end of the day, we need them to partake into the conversation and to partake into translating whatever needs to be done on the ground. So I really, really hope to see that political buy-in, because I feel like that's how much we'll get a lot more done if we have that buy-in. And obviously with the pregnant women being empowered, they will definitely, you know, drive everything going forward. Thank you.
Thanks, Cynthia.
Thank you. And I have 3 key messages. First, that elimination of mother-to-child transmission really is feasible. There are around 30 disease elimination programs at WHO. But hepatitis B elimination of mother-to-child transmission, that component of hepatitis elimination, is really well advanced. There are about 45 countries that already meet the elimination target of the 0.1% in prevalence of hepatitis B in 5-year-olds. And there are many, many other countries that are not far behind. So this is achievable. We have all the tools in the toolbox, very effective tools, and it's very important the community is aware of all those tools. I think we have a huge advantage compared to sort of other disease programs that we do have those available. I think the final message to the community is that the epidemic is at very different stages across the world, and the level of response is very different. So it is not going to be a one-size-fits-all in terms of where are the priorities going forward. In the African region, where there is still high prevalence in 5-year-olds and where there is still low implementation of birth dose, we really do need to focus energies on implementation of birth dose above all else, as well as expanding testing and treatment. Whereas in other low prevalence settings that have been implementing universal vaccination for many years and have already reached low levels, we need to ensure we go the extra mile and identify those women at risk of transmitting and ensure they have antivirals and, as needed, HBIG. And so that applies to the region of the Americas and to the European region, where they're also not doing universal birth dose, they're just doing targeted birth dose. So we will need a slightly differentiated approach for different regions. And we now need to work with the regions and communities in the region to come up with the plan, the phased plan for implementing to achieve mother-to-child transmission elimination of hepatitis B. Thanks.
Thanks, Philippa, for those great thoughts. Leanne?
I think that's great to hear you talk about, like, from the political will to all the things that we already have in our plate to make sure that we can achieve that. And I just want to add something like that. I'm sure that every woman living with hepatitis B would love to have is a buy-in from their own family. So I want to give a call to all the husbands, to all the kids in the family, to all the parents-in-laws, just like be together and support the women during that journey. So not only as a normal, like just a simple, and I mean just like a normal pregnancy is already hard. And a pregnancy of women living with hepatitis B, a lot more support will be there, especially for places where stigma and discrimination against Hep B, and also the feeling of the mom who is giving something back to their child. So we need the buy-in, the support from the family to make sure that the women feel supported.
Thanks, Lynn. That's a really, really important point. And I think that does not get captured anywhere in recommendations and guidelines. And we talk about household contact education and screening, but really, for somebody's quality of life, right? It is about the support of their family and the acceptance and not feeling like you're an outsider. And yeah, as a physician, I find that this is a very difficult time for a lot of women, especially if they're finding out for the first time that they're infected. And it does make them very vulnerable. And I will sometimes bring in the whole family because the husband will have, the partner will have a lot of questions. And it's very difficult sometimes for the woman to even explain it if she's just trying to figure this out herself. And so if the healthcare staff can do some of that education so that the family understands the disease better, that really helps. And I think that's an important role for us to advocate that, that there can be some inclusion, of family members to support during these kind of, during counseling or, doing those education classes you're talking about, Cynthia, spreading it beyond just the pregnant woman. But anyway, these are all such great topics. I feel like we could talk about this for hours. But this is a great start. And I know we all have a lot of work to do. And we're looking forward to all the future collaborations we have here, just even represented here and beyond. And I want to thank everybody for your time, so much for contributing and for everybody sharing from their own region and their own experience. This has been really incredible. So thank you. And then I'm going to hand it over to Carrie to close us out. Thank you.
Thanks, Sue, and thanks to all of our speakers and panelists. It's been such a powerful session, talking not only about the policy and the clinical levels, but also about the how this really affects people, which is so important. Thank you for joining this webinar today. It's one of a series of webinars around World Hepatitis Day 2020. To find out more about our other webinars, visit worldhepatitisalliance.org.